Past the top of the hour, so we'll go ahead and get started. Good afternoon, everybody. My name's Drew Wolf. I'm Senior Director of Business Partnerships here at the Minnesota Hospital Association. I'm really pleased that you can join us here this afternoon. I have the pleasure of running our Endorsed Business Partner Program. So really quickly what that is we do a lot of listening to our site visits and committee meetings to our hospitals and say, what is it that are pain points? What is it that we could help figure out a better way for all of our hospital members? And one area that keeps coming up is pharmacy. There's a lot changing. There's a lot to do with 340B. There's a lot to do with prior authorizations, technology, AI. And so about a year or so ago, we went out and found ourselves a really great partner in House RX who does a lot of this work in a really meaningful way. And Allery's going to take you through that here shortly. But Allery Stiles is the Senior Vice President of Commercial Growth for House RX, and she's going to walk us through how to get through some of those pain points and some of the innovative ways that they have found to help hospitals and health systems navigate that complexity of the pharmacy world. So before I throw it over to Allery, just a couple housekeeping pieces. We love questions and answers and all of that. So please use the chat or the Q&A button at the bottom of your screen at any point during today's session. We'll go ahead and get those answered for you. Today's meeting is being recorded. And so following today's session, I will send out an email that gives you the link to the recording for this meeting. And if you want to rewatch it or forward it to anybody else at your hospital or health system, you are more than welcome to do that. And we'll also share out a version of the slide deck here today, so you have that to digest along with Allery's contact information should you want to follow up with her directly. So with that, I will turn over to you, Allery. It's all yours.
Thank you, Drew. Good afternoon, everyone. Allery Stiles, a little bit of a different name. It's just like Valerie, but no V. Want to be really clear, even though we are an endorsed partner, this will not be a sales pitch. I will give an overview of our company. I would also really just like to give an overview of technology that we've built. So while our company is a pharmacy technology and services company, we have built some pretty killer tech to help automate a lot of processes. It's not meant to either eliminate jobs either, but more almost help upskill other team members to take some load and risk off of your team. I do want to give a little background on House RX. Okay, first couple slides. Also, I hate death by slides, but I do want to plug us a little bit. It's a pretty incredible company. We're quite small as far as comparison to some giant companies out there, but we've got about 250 employees at this point. I'd say 185 of them are pharmacists and care coordinators, and the rest of the team are mostly engineers. But our founder and CEO came from the EMR world, Flatiron, and our COO has been she's also a pharmacist by trade and chief pharmacy officer, but she was the former COO at Trellis. If you've ever heard of Trellis RX, they sold to CPS, which they were then sold to Optum. So there's some kind of shuffles in the market where some entities do not necessarily want Optum in their data. I also come from the EMR world. I come from the specialty EMR world. So as much as I'm over growth at House RX, my heart is clinical and data. So my team, I've always been obsessed with workflows for the clinical team members, getting clicks out of the way and making things designed for a particular specialty. So my EMR, we ended up owning the market in rheumatology, GI, pulmonology, cardiology, et cetera, and ended up building the first pathways, like RA pathway that was approved by a payer. So I ended up in real world evidence and HEOR. And so now, even though I'm over growth, I feel like my mission is the more entities we can partner with and help pharmacists get better outcomes or be able to write a white paper to present at, like, whether it's NCODA or NASP or a big pharmacy meeting, what is ASHP, then I've done my job, right? Then I can get you out of the weeds and help you. Our mission is, like, if I can get you part of a white paper or get published, then we win. So that's a little bit about me. A little bit about our company. So we come in, we will help optimize pharmacy programs within hospitals. Everybody always thinks that it has to be a big fat 340B hospital. It does not, but we'll be honest with you on when one makes a good fit and when it makes sense or not. Our expertise is deep in specialty, and then we built a new pharmacy software and analytics program as well. And I'll throw up some screenshots of that today. Anyone that does not have their own pharmacy within a entity, there's usually a reason. It's either they are unable to hire, 5 to 7 FTEs to staff it. Maybe there's not in-house expertise in the specialty world. It can cost a lot of money to build. And so that's where partners like HouseRx can make sense because we can take on a lot of the financial risk and we can bring that expertise. And then it's my risk to staff an on-site pharmacist or to help partner with your pharmacy team. So I think a lot of companies almost only want to work with 340B entities. We want to be the company that it's just a good partner. So we don't only work with 340B entities. I have a lot of clients that are non 340B, which I think is a testament to our company because if we can find margin in the non 340B space, then we must be doing something right because it kind of makes you like a scrawny desert animal that's able to find margin when most can't. Do we also work in the 340B covered entity space? Absolutely. We have several RRCs, Dish. So happy to speak with anyone on whatever side you're on. Okay. As far as what we do, we provide pharmacy services, whether it's expertise, staff, optimization. We provide the technology. We have a web-based pharmacy software and analytics program. I think a lot of companies, they'll provide a pharmacy software, but they almost want to hold that data hostage and they want to sell your data. We took the opposite approach. We want to empower our partners with their data. So you'll actually see some screenshots of our analytics program today. One last thing, and then we'll jump in. Got to brag on ourselves. So, some quality metrics out of HouseRx. We actually are publishing a few papers and case studies on our most recent data, but our average time to fill, I think it's actually under 3 days now. So, this needs to be updated. I just presented at a healthcare advocacy conference last week. Over 94% adherence rate. PDC is over 90%. Our patient NPS, I think, is actually a 9.4 as of last month. So really proud of where we are in the market and how we're able to partner with entities out there. So I'm sure everyone on the call, everyone hears about AI. I would say a few years ago, everyone wanted to talk about AI. It wasn't really there yet. But now, obviously, it's just exponentially growing and growing to where people are kind of scared. And then people are getting scammed because AI is getting so good. So I've seen some technology entities out there where I don't know if anyone was at the Healthcare Advocate Summit in Vegas last week. I had a talk there. My COO had a talk there as well. But I was speaking with a VP of pharmacy, and she was like, I meet with these companies, and they're like, well, we'll just build you what you need, whatever you want, we'll build it. And nobody really has time for that. So I'm going to present what we have. And so you can say if it's something of interest to you or not. So we have smart prior auth or smart PAs. So that's ready to go on both the pharmacy benefit and we're also building on the medical benefit as well. So when people talk about AI, I can tell you what's done. We could probably build it too, but I'd rather just tell you what we're experts at, and we're experts in the pharmacy space. So deep integrations with EHRs. I know the ones off the top of my head, Epic, I think Cerner, I think on Meditech as well. NextGen, iKnowMed, Onco EMR, so specialty EMRs and hospital EMRs. But a lot of people don't have that Fire API experience or that deep integration. Some of our founders, plus me, we came from the EMR world. So we're able to kind of like get in and know what needs to be done so that the EMR company can't just like nickel and dime you for everything or avoid integrations that need to happen. Anybody? I wish you guys could chime in on guessing what 20 to 50, what kind of stat this might be. 20, 50 minutes, average number of minutes it takes in the industry to do a prior auth. So when we're looking at how can AI empower entities better, what about 30 to 60? What could this be? 30 to 60 seconds to do a prior auth with our smart PA program within our software. So it's kind of a game changer out there. The next phase will be on the medical side, the medical prior auth side as well. So if any entities on this call have an infusion suite, in-office or in-house infusion suite, we can help there as well. Okay. So as far as AI, it is finally here. I've seen some other companies try to do this, but I know that they're having trouble with integrations on the PBM side. Ours is done. So again, the right relationships, because a lot of companies they'll kind of fight you on it. So having the right relationships and the right know-how to be able to get in there and fight them the right way is what's empowered HouseRx to be the first pharmacy software with prior auth AI built in. So our smart PAs, I just wanted to throw up a few screenshots. I hope anyone isn't too like nerded out or teched out with this, but I think it's important. There's one thing to talk about things. It's another to be able to show it and be able to say like, we actually have it. Okay. So when you go in and when a auth is submitted, our software, let's say there's like 5 questions that need to be answered to put a patient, let's say on Verzenio. So also, by the way, we did a stat on our services side where Lily did a pilot program with our pharmacists doing 3 to 5 day check-ins on Verzenio versus a standard 10-day. I'm sure for the pharmacist on the line, you understand that Verzenio has adverse effects typically within 3 to 5 days, and there will be higher abandonment because patients will have nausea or diarrhea and you need a sooner check-in. So we ended up, God, I think we improved our adherence and persistence, but it was like over 400% by just tailoring programs by drug. So these are things that we would work with your pharmacy teams to do. Anyway, back to our smart PA. So within our software, we can automatically answer the questions to do the prior auth. So there you go in, you check, and that's because we have the integration with the EMR. So the patient chart note is automatically pulling in from the EMR and pulling all the pieces of data enabled in order to give you the ability to do the prior auth. We also have prior auth trackers and queues. So any financial assistance dashboards, prior auth dashboards out the wazoo, we have them. So you're able, obviously there's no PHI on this screen. Okay. So this is all fake patient data, but you're able to see like the order number, the date it was initiated, what the insurance is, how it came over, what the medication is. We can pull the SIG in, what the status is of the prior auth. If there's a next follow-up, is it going to be self-administered, right? So now we're thinking provider-administered drugs as well. So we wanted you to see kind of what's coming and what we have on our dashboards, but you can see like which ones need submission, which ones need follow-up, which ones are in progress, what are completed. Well, even though this one's denied, they're not going to pursue this drug. Maybe it's not on formulary. Maybe we need to go back and change the script, but you'll be able to see like what's approved, what's denied, what's completed. Okay. As far as other technology abilities, we have triage texting. So even though the patient can't go on, or maybe it can't be dispensed in house and you have to send it out, you still want to make sure the patient gets on therapy and you want to make sure that SP gets notified without just like sending it out and hoping patient gets on therapy. But we're able to go back into the EMR. We're able to send we're able to send a prescription from the EMR to the external SP. We can put in the triage reason. Maybe there's a teach required. Maybe it's an injection with a teach required. Maybe there's no teach required, but we're able to go in and say how we notified the patient. We also do have texting for patients as well. I could go pull some screenshots to make sure you have that in our follow-up when Drew sends the deck out. I can add some texting screenshots in there as well of how we communicate with patients. As much as we would love for everything to be integrated, there's still faxing in the world. I think everyone on this call knows that. So as far as like automated faxing going out of our system, we have that built in. We can add as much detail as you want, and then you get a final notification of everything's been triaged out. Wanted you to see a few screenshots of our software. Oh, it looked like I froze for a second. Tell me if you're having trouble here, Drew. Anyway, wanted you to see our pharmacy software, how it works, all of the different queues that it can work in, because maybe you have prior auth employees, maybe you just have pharmacists that you want to be in certain sections. We can also show like a one screen view so that everything's on a single screen, but wanted you to see that access to your analytics program as well. One thing we hear in the market often is, oh, I need to run this report out of Liberty or Pioneer or QS1 or Enterprise RX or WAM. And they're able to get some reports, but maybe they can't get like claim level detail, or maybe they're relying on a third party to run those reports. We kind of want to be the opposite. We think it'll come back to us tenfold if we empower entities with their own data so that they can report on them on their own and pull what they need on their own. Also feel like you could probably go to, local payers and negotiate your own shared savings program, right? So again, that's the world I came from, where I got to go beat up on payers before to help for reimbursement rates. So we want to empower entities with that. So we have our web-based pharmacy software. You're able to see all the different queues, right? And then you can go in and you can slice and dice your data any way you want, whether it's by provider, whether it's by payer, whether it's by drug, whether it's by even a payer mix, right? Because maybe it's like individual plans, maybe it's like Med Advantage plans, maybe you need to go pull Medicaid plans, completely up to you. And then full drill down financials as well, for maybe you have a VP of finance or a CFO that you want to show, like, look how much we're killing it. So those are always the wins for me when we partner with pharmacies and I can give killer reports to a VP of pharmacy that they can take to their CFO to be like, look what we're doing with House RX. Please give me a raise. Those are my favorite programs because you get to flex on them and we just get to be the partner that helps you get there. Our adherence, I actually think we're over 91% at this point, but it's nice to just see that you can track it on your own and run your own reports. Same thing on average days to fill. So an average day to fill on a retail med is going to be very different than a specialty med, right? So when as far as like getting a prior auth and patient coming to get it, or sending out to a patient if you want to have it delivered by courier, we can help coordinate with all of that as well. I did want to summarize again, quality metrics that HouseRx has out here. Our average time to fill, I think it's 3.8 days, average adherence over 90%. These stats are going to be ancient within already because we released our prior auth AI at the Community Oncology Alliance meeting this year in April. So now our prior auths, it's less humans submitting our prior auths within 2 hours because these are our human stats. But now instead of prior auths taking, 20 minutes to 50 minutes, they're done in seconds. And I think we have a 85% submission rate with a 93% accuracy rate. So these stats are about to just get blown out of the water. I could probably tell you how great we are till the cows come home. I really made this overview about our technology I am happy to share our services, what HouseRx does as far as services. When we work with pharmacies, we'll come in, we'll stand up a new pharmacy, we'll come in, we'll help optimize an existing pharmacy, we'll do an analysis for you at no additional charge. We can come in, we can help look at getting access to additional specialty medications that maybe you didn't have access to before that you thought maybe were limited distribution, where we can help look at the wholesalers. We can help look at your GPO pricing. If you need specialty accreditation, whether it's URAC or ACHC, our team can look at that. Whether it's employee programs or closing the loop internally programs, whether it's a specialty um, chronic disease clinic that you want to keep those referrals in-house as well, we can help set those up. So just kind of want to flex on like everything HouseRx can do. Don't want you to think that we're just technology. Remember all of the pharmacists and care coordinators I have, but when our team calls, just like when you call now, it looks like your entity is calling. And when our team calls, no one is saying House RX. We're saying XX Hospital Pharmacy or XX Health Pharmacy so that patients take those calls. Or if they miss that call, they call you back. Because when outside entities call, I know my parents are terrified of getting scammed. I've scared them into it. So I know that they only call back their clinic or their provider, or if they are used to working with their local hospital pharmacy, they'll call them back. So want to be really clear on how we will work with folks. And then we have a lot of folks that they'll work with a third party to help them stand up a pharmacy, or they will stand up their own, but maybe there's turnover. Maybe someone needs to go out on leave. Maybe a pharmacy software is being sunset and it's outdated or it wasn't designed for specialty. Maybe they don't have in-house expertise on specialty accreditation. Maybe some big salesperson told them they were going to make all this money and then they get going and it's barely breaking even. So it's really nice to have a partner that's honest with you up front of what the possibilities are and what's not possible. So we like to pride ourselves on being very upfront with folks and never over promising. So very high level on purpose. I told Drew, because we had 45 to 50 minutes booked, I told Drew, I was like, if this takes more than 30 minutes, then that's ridiculous. Folks are trying to like scarf down lunch and get through their day. And what I don't want to do is just drone on with 90 slides for you guys. I'd rather just give a high level. And if you guys have questions, I'm here to answer them.
Yeah, great time to enter it into the Q&A or the chat button if you have any questions you'd like to ask Allery. And I'm sure the time sensitivity is much respected. As somebody who spent their first 10 plus years of his career in a retail pharmacy, I know lunch is like a pipe dream some days. So this is probably a welcomed piece. So just one question right now, Allery, that came in. Is there a certain profile of hospital that is better than another for these types of services? You had mentioned 340B is great, but doesn't have to be.
So I hate saying that there's any bad profile. I will say there's different ways to look at it. If you look at the most revenue generating or resource generating, those are generally going to be rural referral centers and dish hospitals. Does that mean a critical access hospital or a sole community or a non 340B hospital won't benefit from specialty dispensing or a pharmacy in-house? No, that does not mean that at all. So I want to be really clear. It's just you need a full analysis on any non 340B entities or any other different 340B designation.
Perfect. That's
Can I answer
great.
that clearly?
Yep, perfect. No, that's good. Keep the questions coming in. Majority of Minnesota hospitals have Macro Helix or Century or SunRx as kind of their TPA. Talk about that, how this
So
works.
We are TPA agnostic. If someone does not have a pharmacy set up and they want us to come in and set up a pharmacy, we have TPAs that we're happy to get them set up with. If they want to choose their own, that's fine. I know the founder and chairman of SunRx. I know the Macro Helix team well, and we work well with all of them. If anyone's unhappy with their TPA, we can always help them set up with another one. So.
Perfect. Sounds good. What's a reasonable first step? So if you're on the call and you're going, I don't know, is this for me? Is it worth the lift, if you will? Is the juice worth the squeeze? Where's a good place to start? How do you get going? Walk through those implementation first pieces.
Yeah, I'll give you two answers. We will tell you if the juice is worth the squeeze or not. I think there's companies out there that will sell you anything and they'll be like, yeah, we'll sell you a pharmacy. And I'm like, oh my God, what if they just charge you out the wazoo and then now it's a cost center versus a resource center for your patients and revenue, right? So, two ways to get started. If you do not have a pharmacy and it's something you want to have as a resource for your patients and providers, HouseRx can do an analysis and we can get full volume from any scripts coming in. Okay, and look at standing up a whole new pharmacy for you, getting your NCPDP, getting your DEA, getting all the credentialing, looking at the space for the build out. We provide the software, the barcode scanners, the label printers. Like think of an easy button. It's not easy to stand up a pharmacy, but think of HouseRx as like an easy button partner. We staff it as well to where, let's say I have a pharmacist on site and they have a major illness. It is my responsibility to staff another pharmacist on site or to fly one in for any planned or unplanned PTO, etc. We will run it end to end, even your P&L. So the entity gets a monthly or quarterly statement on how's everything going with detailed line item P&L. Okay. If a entity already has a pharmacy, whether it's a specialty pharmacy or not, we can do an analysis. We do not charge for it. An analysis looks like a full script export plus a dispense export. It's a standard numerator denominator. And we look at how's it going? What's the opportunity? What's the capture rate? What's really interesting is you can run a dispense report out of pharmacy softwares without an EHR report, and they'll say, oh, you got a 90% capture rate. Well, you don't have a true numerator denominator. So it takes both to do a true analysis. And that irks me about pharmacy softwares out there is they'll report out, you've got this much capture rate, but it's not a true picture. So we will do that analysis for you. You're probably thinking that we tell everyone like, oh my God, we could capture so much more. Actually, I'd say half the groups we do analyses for, the report comes out and we shake their hand and say, you're doing great and you don't need us. Maybe you'll want our technology one day for prior auth AI or our analytics program, but half the time they don't need our services because maybe they have it, maybe their whole pharmacy team is just killing it. Often when they need our services, it's not because a pharmacy team isn't killing it. It's usually because of limited access to drugs that maybe a wholesaler has limited. So I think some people think that we're going to come in and tell someone they're doing a bad job, and that's not it. There's just simple impossibility of them being able to go in and grab what we're able to grab. So I want to be very clear on that. But the way they work with us is we can set up a whole new pharmacy, or we can come in and optimize an existing pharmacy. But
yeah, that was actually going to be my next question was the inventory, because I know when we first were going through the vetting process, one of the things that was really appealing to the pharmacy group that kind of pre-vetted this arrangement was you had access to some specialty drugs and gave you a list of 10 or whatever it was and said, can you find these? Because these seem to be really difficult to get. Can you expand on that just a little bit, how that works?
It's really just our team coming from the specialty world and being able to unlock access. Some of my team on the commercial team came from GPOs, group purchasing organizations, and
Mhm.
wholesalers, like the big distributors. So they know how the sausage is stuffed to be able to access, I hope that's okay to say, to be able to access drugs versus just most entities will email and they'll say, can we get this? And people will take the easy way out and they'll say no. And it's just like, you just didn't know you had access to it when we know how to kind of like get in there and beat up on everyone. So, yeah, I remember that list. I think it was like 10 out of the 11 we were able
Mhm.
to get.
It was an impressive list. We were pleased to see that and pushed us in the right direction. Well, I'm not seeing any more questions coming in, and I know we're right at the bottom of the hour. Any closing comments, Allery, from you before we wrap things up?
Mainly just a reminder that my goal and my pharmacy team's goal is to partner with pharmacists, VP of pharmacies, director of pharmacies on improving patient outcomes. If I can get them out of the weeds and so that they can be at conferences presenting on white papers on outcomes, like that's a win. That's such a huge win for me. So that they can go like run their own data and present their own stories. So that's always the biggest win for me.
Terrific. Well, thank you so much for your insights today, your energy. Wonderful presentation. Really great to hear. For everybody who's on today's webinar, I will be sending out a version of the slide deck, a recording of today's webinar, so you can again go back, re-listen, forward to others in your hospital or health system, and I'll share back Allery's information should you want to ask any offline questions or to take any next steps. So thank you, everybody, for registering today. Appreciate your time and attention, and appreciate you joining us here with the Minnesota Hospital Association.
Thank y'all. Thanks, Drew.